Bismillah ar-Rahman ar-Rahim. Mammography ACR, breast imaging, reporting and data system lexicon interpretation. Maybe most of us working in the field of breast imaging know the meaning of the word by RADS, but not most of us know the meaning of the word lexicon. And why is it called imaging reporting and data system and not, for example, data collection? And what is the impact of using the lexicon on reporting and the data system? We will start by answering the first question, what is a lexicon? And if we look up the dictionary, we will find that the word lexicon means a book containing a clearly defined vocabulary list used by a person in a language or in a branch of knowledge. Actually, using the lexicon ensures that when a group of people use the same terms, the terms mean the same thing for every individual person in the group. And before answering the second question, why is it called a system, we should know that the RADS initiative was instituted by the American College of Radiology in the late 1980s to address a lack of standardization and uniformity in mammography practice reporting. And the fifth edition of the ACR RADS Lexicon Atlas has been released in the year 2013. And actually it is called a system because the ACR RADS Atlas contains a lexicon of morphology descriptors, a reporting structure with final assessment categories together with a framework for data collection and auditing. And now we move to answering the third question, what is the impact of using the lexicon on reporting and data collection? Actually, using the lexicon reduces ambiguity of report content, and that means that we have a clear and consistent communication between radiologists and clinicians. On the other hand, it offers a more quantitative approach, which means that we have better quality control with less errors in interpretation. This is all reflected by the fact that the radiologists, clinicians, and even the patients themselves can join in the selection of the most appropriate management protocols. I will divide the lecture into two parts. In the first part, we're going to discuss the lexicon of mammography morphology descriptors, and we're going to specify the differences between the last lexicon and the 2013 lexicon. And in the second part of the lecture, we're going to discuss the reporting structure with final assessment categories. And now we'll start by the lexicon of mammography morphology descriptors. The descriptors in the RADS lexicon were selected on the basis of their ability to discriminate between benign and malignant findings. And they are used to describe mammography-identified lesions, including mass lesions, calcifications, asymmetries, intramammary nodes, focal duct dilatation, and associated features. And whenever we find any of these findings, we are also asked to specify the exact location of the finding and to specify the number of lesions. We will start by specifying the exact location of breast lesions. And we all know that in the medial lateral, or on the CC view, we usually report the outer and the inner breast quadrants, and in the medial lateral oblique view, we report on the upper and the lower breast quadrants. And the first step in lesion localization is the laterality, is to identify the laterality, or in other words, to say whether the lesion is present in the right or in the left breast. The second step is that we have to specify the quadrant. For example, this is an upper outer quadrant breast mass lesion, and this is a lower inner quadrant lesion. Then we have to specify the distance from the nipple and the depth of from the skin whenever possible. We also have to specify the number of lesions. For example, we might have a single lesion, a bilateral lesions. We might have multifocal lesions which are present in the same quadrant or less than 4 to 5 centimeters apart. Or we might have multicentric lesions which are present in more than one breast quadrant or more than 4 to 5 centimeters apart. And now we'll start by the mass lesions morphology descriptors. And whenever we have a mass lesion in the breast, we should describe the shape of the lesion, which might be either rounded, oval, lobulated, and irregular. And in the new RADS lexicon, they removed the lobulated shape, and we're only left with the rounded, oval, and the irregular shape. We also have to describe the margins of the lesion, which might be either circumscribed, the obscured, microlobulated, indistinct margins, or the speculated margins. And there is commonly overlap between the use of the obscured and the indistinct margins. If we look at the obscured margins, that means that we have a well-defined lesion, but the surrounding tissues are overlapping a part of the margins of the lesions. While the indistinct lesion is a lesion which is in itself indistinct, irrespective of the surrounding parenchyma. We also have to describe the density of the lesion, which is in comparison with the surrounding breast parenchyma. We might either have fat-containing lesions, lesions of lower density, lesion of equal density to the surrounding parenchyma, and lesions of high density. And if we look at the three groups, we will find that going from up to down, we are actually moving from a benign to a malignant pathology. And now we'll see some applied examples. For example, these three lesions, the three can be classified as rounded in shape. But if we look on the first lesion, we can see that it is well circumscribed, and even we can see that it has a capsule, which a part of the capsule is seen here, and it is fat containing because of this lucent area within the lesion, and actually this was a hamartoma. If we look on the second lesion, we can see that the margins are speculated and it is of high density as compared to the surrounding breast parenchyma, and actually this lesion was a carcinoma. If we look at the third lesion, we will find that it has circumscribed margins and it is again of high density, but this time this lesion was a fibroadenoma. This is another example. For example, these three lesions can be classified as irregular in shape. But if we look on the first lesion, we will find that it has speculated margins and it is of high density, and this was a carcinoma. If we look at on the second lesion, we will find that it has microlobulated margins, and again it is of high density, and this was also a carcinoma. While the third lesion, it had obscured margins, the surrounding tissues were availing part of the margin of the lesion, and it is of equal density to the surrounding parenchyma, and actually this was a fibroadenoma. And now we move to the calcifications morphology descriptors. And again, whenever we find calcifications within the breast, we should describe the morphology of the calcification and the distribution of the calcification. And according to the morphology, we might have a benign morphology, calcifications of intermediate concern, and suspicious calcification. And in the new RADS lexicon, they said that we usually manage the intermediate and the suspicious calcifications by the same line, and that's why they removed the intermediate group and it was included under the suspicious group. Under the benign calcifications, we have a very long list, and after a while I will show you some examples of these. But what has changed in the new lexicon is that they removed the lucent-centered and the eggshell calcification, and they were both included under the rim calcification. And one common feature which combines all benign calcifications is that they are all macrocalcifications. Looking under the suspicious calcifications, we have all three subtypes, which are the fine pleomorphic, the fine linear, and the fine linear branching calcifications, together with the group which was formerly classified as of intermediate concern, and these are the amorphous and the coarse heterogeneous calcification. And one common feature also which combines suspicious calcification with the exception of the last subtype is that they are all microcalcifications, and again I will show you some examples after a while. And now we move to the distribution, and the distribution of calcifications might be either diffuse, regional, grouped calcification, which we formerly called clustered calcifications, linear and segmental calcification, and moving from up to down in the distribution, actually we are moving from a benign to a malignant calcification. And now we're going to see some applied examples. For example, this is the skin or the dermal calcification. These are the vascular calcifications. This is the popcorn calcification, which is commonly seen in involuted adenomas. This is the rod-shaped calcifications, which we commonly see in plasma cell mastitis. These are the rounded calcifications, the dystrophic or the suture site calcifications seen at operative beds, the milk of calcium calcification, and the rim or the eggshell calcification which characterize the oil cyst. And now we'll see examples of the suspicious calcifications. These are the fine pleomorphic calcifications. These are the fine linear branching calcifications. These are the amorphous calcifications which have no specific shape or distribution or size. And these are the coarse heterogeneous calcifications. And according to the distribution, these are the diffuse calcifications. This is the regional calcification which occupies a large area of the breast. These are the segmental calcification which follow the ramification of ducts. And these are the grouped or the clustered calcification. And these are the linear and the linear branching calcifications. And now we move to the asymmetry morphology descriptors. And if you ask me how do breast asymmetries look like, I will simply answer you that the asymmetries look like nothing. They lack the convex borders of masses and are often interspersed with fat. They also lack the radiating lines or tissue retraction of architectural distortion, and they lack the tubular branching appearance of a dilated duct. We formerly classified breast asymmetries into either global or focal, but now asymmetries are classified into a single view asymmetry or the simple asymmetry, the global, the focal, and the developing asymmetry. And again, moving from up to down, we are moving from a benign to a malignant asymmetry. We will start by the first subtype, which is the single view or the simple asymmetry. And the single view asymmetry is an asymmetry which is only seen in a single view. And they usually contain interspersed fat within. They are usually caused by the superimposition of normal fibroglandular breast tissue, and therefore they are mostly benign in nature. The second subtype is the global asymmetry. And the global asymmetry is an asymmetry which occupies more than 25% of the breast or at least one segment. It is seen in two views and it usually requires recall for further assessment. The global asymmetry might be either benign or malignant, but what raises the suspicion of malignancy is the presence of an associated palpable mass, associated breast erythema or edema, or associated calcifications or distortion. For example, this is an example of a suspicious global asymmetry. We have an asymmetry here which occupies a large area of the breast, but unfortunately this asymmetry was associated with skin thickening and pathologically enlarged axillary lymph nodes. An ultrasound examination was requested and it revealed an underlying diffuse edema pattern of the breast with edematous echogenic fat lobules which are delineated by interstitial edema lines with overlying skin thickening. And unfortunately, on looking on the axillary nodes were pathologically enlarged and there was no associated mass lesion within the breast, and actually this was a case of an inflammatory breast carcinoma. The third subtype of asymmetries is the focal asymmetry. And the focal asymmetry is an asymmetry which occupies less than 25% of the breast. It is seen in two views, and it may be benign or malignant, but the incidence of malignancy is usually higher. And in these cases, we should also proceed to another imaging modality. In this case, we performed a tomosynthesis examination, and actually on the tomosynthesis, it looked like a mass lesion rather than an asymmetry. This was her ultrasound examination, which revealed an intracystic papillary growth, and this was the contrast mammography examination, which showed enhancement of these papillary lesions, and actually this was a case of an intracystic papillary carcinoma. The most serious of all asymmetries is the fourth subtype, which is the developing asymmetry. And the developing asymmetry is either new or has increased in size when compared with previous examinations. For example, in this case, this is the 2006 examination and this is the 2008 examination, where we can easily see that the patient has developed a right retroareolar asymmetry. An ultrasound examination was performed and it revealed an underlying carcinoma. We also have to report on special cases. For example, if we have a single dilated duct, like in this case, we should recommend for an ultrasound examination, and an ultrasound examination showed a large intracystic papillary growth, which showed increased vascularity, and actually this was an intraductal papillary carcinoma. We should also report on the presence of skin lesions, for example, dermal moles, and for the presence of intramammary lymph nodes. We should also report associated findings, for example, skin retraction, skin thickening, nipple retraction, and coarse intrabiculi, which usually indicate underlying breast edema. And now we're finished with describing lesions, and or in other words, we're finished with the lexicon of morphology descriptors, and we are going to move to the reporting structure with the final assessment categories. A good mammography report should include the indications for examination, a description of the overall breast composition, a clear description of any important findings, comparison to previous examinations, the final assessment category, and the recommendation for management. And actually, in the first part of the lecture, we have finished with the clear description of any important findings, and now we're going to move for explanation of the other points. And I think all of us working in the field of breast imaging know quite well that the main indications of mammography fall under two subtitles. The first is detection, and that means that finding unsuspected pathologies, and that's what we actually do in screening programs. The second subtitle is the diagnosis, which means classifying these identified pathologies into benign and malignant. And now we'll move to the breast density description. And formerly, we used to describe the breast density, to categorize the breast densities into an ACR1, ACR2, ACR3, and ACR4 according to the percentage of fibroglandular tissue within the breast. But actually, this has changed into another classification where an ACRA means we have a fatty breast, an ACRB means we have scattered fibroglandular tissue, an ACRC means we have a heterogeneously dense breast, and an ACRD means we have an extremely dense breast. And we are also asked to write, whenever we say, for example, it is an ACRA breast, we should write that this an ACRA breast means that it is a predominantly fatty breast parenchyma. And the reason why we have to describe the breast density in our reports is because as we move from an ACRA to an ACRD breast category, both the sensitivity and the specificity of mammography decreases. For example, this is a breast which can be classified as an ACRA or an ACRB with scattered fibroglandular tissue. And actually, all of us can easily identify this very small carcinoma within the breast because it is simply a predominantly fatty breast parenchyma. While on the other hand, if we see such a heterogeneously dense breast, even if we see the carcinoma on the contrast mammography and on the ultrasound, it is very difficult to pinpoint the actual site of the carcinoma in this type of breast because it is simply a heterogeneously dense breast parenchyma. We also have to compare the mammograms with previous films. For example, this was a lady who performed a left breast conservative surgery, and this was her first follow-up after operation. There was a diffuse edema pattern of the breast with skin thickening and coarse intrabiculi, and she came for her next year examination. The skin edema has resolved, the edema of the whole breast has resolved, but unfortunately she developed the speculated outline mass lesion at the operative bed. And even without going to a further ultrasound examination, we can say that there is an operative bed recurrence in comparison to the previous 4 years examination because there was no, it is not an operative scar, there was no scar in the previous examination. And actually, this was proved by a further ultrasound examination, and this was a case of an operative bed recurrence. At the end of the report, we are asked to write a BI-RADS assessment category. And the BI-RADS assessment categories are designed to be concordant with specific management recommendations. We should also include the text corresponding to each category, and that means if we say that this is a BI-RADS 0, we should say that it is an incomplete examination, and we need additional imaging evaluation or comparison with previous film. If we say we have a BI-RADS 1 that means we have a normal examination and there's nothing to comment on, and the routine mammography screening is recommended. If we say we have a BI-RADS 2, that means we have benign findings and routine mammography screening is again recommended. If we say we have a BI-RADS 3, that means we have a probably benign lesion with an incidence less than 2% of malignancy, and the short interval follow-up is suggested. If we say we have a BI-RADS 4 category, that means we have a suspicious lesion, and this is further subclassified into A, B, and C according to the level of suspicion. If we have a BI-RADS 5, that means we have a highly suspicious of a lesion of malignancy, and appropriate action should be taken. While a BI-RADS 6 means that we have a known pathologically proved malignancy, for example, in these cases which receive neoadjuvant chemotherapy, and surgical excision is recommended when clinically appropriate. The linking of assessment categories with concordant management recommendations further enhances sound medical practice. However, in the 2013 Lexicon, we are allowed to uncouple assessment categories and management recommendations in some selected cases. For example, we can have a BI-RADS 3 lesion, but this lesion is present in a high-risk patient, or if the patient or the clinician insists on a biopsy. We can still say that this is a BI-RADS 3 lesion and recommend for a biopsy without raising the category of this lesion to a BI-RADS 4 category. But of course, it is not accepted at all to say that, for example, we have a BI-RADS 4 or a BI-RADS 5 category and then we recommend for annual follow-up. This is not accepted at all. And finally, we have to clarify some points. A BI-RADS 0 should be used only in screening, and in the diagnostic context only it should be used when complementary examinations are not immediately available. To use a BI-RADS 2, we should either have an involuted adenoma, fat-containing mass lesion, benign calcifications, intramammary lymph nodes, postoperative sequelae, implants, and clips. A BI-RADS 3 should be, if we are following up a BI-RADS 3 and we have any increase in size or extent during the short interval exam, we should recommend a biopsy, and the BI-RADS category should be raised to a BI-RADS 4. A BI-RADS 3 should be used only for circumscribed solid masses, for focal asymmetry, solitary group of punctate calcification. There is debate concerning the use of BI-RADS 3 category in screening programs because it might lead to unnecessary biopsies, and in the same time it might lead to delayed diagnosis of breast cancer. Therefore, we should conduct a complete diagnostic imaging evaluation before using it in screening programs. And BI-RADS 4 and 5 categories should not be used for mammography screening except after full diagnostic imaging workup is performed. And at the end, definitely using the standardized mammography descriptors and the BI-RADS final assessment categories have proved to be a unique resource for measuring and improving the quality of mammography interpretation. It provides an important assessment tool to audit interpretive performance, and establishing a clear line of communication between radiologists and referring physicians is crucial to improve quality patient care and is very useful in clinical research. And thank you.